I think it's an ambitious goal. I'm a little bit concerned that there are some challenges that make full adoption unlikely within that timeline. I think we've made significant progress in primary care and some specialty areas, but I think to achieve universal adoption, there are some significant structural, financial, and operational challenges that probably need to be crossed. So a few of the challenges. So I think some conditions like oncology, rare diseases, neurology involve pretty high cost therapies with kind of a reliance on case mix to try and make the math work. So risk sharing at the practice level sometimes is difficult. Oncology, for example, there's just like such a plethora of new treatments and sort of new treatment paradigms that come out that sometimes are hard to forecast and they don't always align with rigid cost benchmarks. I think practices have struggled with some of the financial uncertainty and the administrative burden of value-based care. There is a lot more in terms of the documentation and that enables sort of the risk stratification for value-based care, but those documentation burdens can be pretty onerous. Sometimes the safety net providers and independent practices can really struggle with the infrastructure requirements and the data analytics requirements. They don't have the staffing readily available to try and support them through these models. And then I think some models have had kind of mixed financial outcomes. So the OCM, the oncology care model, which ran from 2015 to 2021, it showed pretty mixed financial outcomes. I think some practices did very well, but other practices failed to generate meaningful savings and then led to practices dropping out towards the end of the model. And then CMS ultimately didn't save too much money either there. So I think there's a few key challenges, but I think where value-based payment models are more likely to succeed are in the context of the growth of Medicare Advantage. So Medicare Advantage now is the primary way in which most seniors are accessing Medicare. So Medicare Advantage being a privatized form of Medicare and inherently capitated has unique alignment with value-based payment approaches. And then I think in primary care and then some specialty care models like maternity bundles, joint replacement episodes, it's really shown more consistent success. But, I'm an oncologist and I work at a company that supports oncology value-based care. And I don't think that the field is inherently at odds with the value-based care. I just think that we have to solve for the business model to get us there. And in my opinion, a third party enabler like the company that I work for is, I think, key to trying to remove some of the sources of friction that I had just outlined. Both CMS and private payers, I think, have really important roles in value-based care innovation. So I think CMS has certainly led the way in sort of setting the policy framework, kind of driving practice participation and helping build that muscle because it's not something that practices can do overnight. It requires a certain type of staffing, technological enhancements, kind of getting used to it. So CMS, I think we would be not where we are with value-based care without CMS leading the way, kind of driving, definition of these quality metrics, reporting requirements, benchmarks, pushing for accountability through some of their mandatory models. The recent focus on health equity also was necessarily novel. I think CMS prioritized it, and now increasingly commercial payers are following suit. But I think where private payers have outpaced CMS is that they I think are firstly in different markets, right? CMS obviously has jurisdiction over Medicare and Medicaid, but private payers have access to the Medicare Advantage markets and the employer-sponsored markets. And so they've been able to, I think, create more customized value-based care contracts, more niche specialty care models. They have not necessarily needed to wait for CMS pilot programs to read out before kind of implementing their own models in oncology, orthopedics, what have you. I think payers can differ too in terms of like how they leverage real-time claims data, predictive analytics, AI you know. So I think that there's potentially differences there. Yeah,
Okay.
and I think private payers also like can do things like offer direct contracts with health systems and things like that, which CMS cannot
Yeah.
do. I think the most effective value-based care strategies probably would come from more public-private collaboration. And I think CMS has tried to get there because explicitly in things like the oncology care model, the enhancing oncology model, they say that they would like these to be multi-payer models. And by that, they mean that they would like the framework that they've set up for OCM or EOM to be mimicked by commercial payers so that a greater share of a physician's panel kind of follows the exact same framework for value-based care. So providers are not dealing with like a number of different disjointed requirements or timelines. I think there was actually a little bit more private payer participation in the OCM, less so in the EOM. But I
Okay.
mean, CMS, I think, has always been outspoken in wanting more public-private collaboration. So the MSSP or the Medicare Shared Savings Program is kind of synonymous with the accountable care organization effort, and it's been a cornerstone of CMS's value-based care strategy. I think it has always sort of centered primary care physicians as the cornerstone of the program, and its effectiveness has been mixed, especially because of the fact that, like, I think specialty medicine just requires sort of a different framework. But in general, I mean, MSSP has shown some cost savings, some gradual cost reductions, but I think overall the savings have been modest. For the number of ACOs that have been developed, I think like a couple of years ago, maybe the entire program had saved Medicare $2 billion or something like that. There has been some interesting analyses that I think are worthwhile to note, which is that physician-led ACOs tend to perform better than hospital-led ACOs. And I think it makes sense because we see sort of similarly in the enhancing oncology model, for example, physician participation has really outpaced hospital participation in the EOM. I think, with physician-led groups, there tends to be pretty aligned incentives overall. So if a group has decided to participate, they're able to orient their framework accordingly, as opposed to, I think, for example, a hospital-led ACO, which might struggle to both cut costs, but also kind of maintain the revenue to support its expensive infrastructure. Um, but I think the ACOs have really led to sort of like clean principles around what reduces care. Obviously, sometimes the sources of cost reduction vary by specialty, but in the ACO context, really thinking about how we improve care coordination, use palliative care more effectively, use remote monitoring tools and patient navigation. They've all been really helpful tools and I think translatable lessons to kind of other value-based care efforts. So the QPP involves the merit-based incentive payment system or MIPS, and it's kind of the default program that CMS has physicians participate in if they're not part of an advanced APM or an advanced alternative payment model, like some of the ACOs that share downside risk with Medicare. So I think the MIPS program has faced, probably rightfully so, significant criticism for its weighting formula, the complexity of it, and sort of the financial impact on specialists like oncologists. I think it was designed to incentivize high quality, cost effective care, but the formula has been challenging for oncologists, and I think the payment adjustments have been rather underwhelming. So, just to summarize, the MIPS scores are based on four weighted performance categories. There's quality and cost, and they're both weighted equally, I think, at 30%. And then the remainder is around sort of some process activities. One is called improvement. So that's where, physicians are scored on their participation in things like care coordination, patient engagement, population health initiatives, and then another category that's about interoperability. So whether practices are using certified EHR technology for data sharing. Um, the one immediate problem is that because of sort of the high emphasis on cost, um, there's like an automatic kind of penalty that oncologists face in participating in the MIPS program. Oncology care is really, the vast majority of spend is in these high cost drugs and complex therapies. They're really less weighted on things like, the number or, size of like physician visits and things like that, like really completely dwarfed by the drug spend. And so the cost category really penalizes practices who use expensive yet necessary evidence-based treatments. And I think we had like done a study that I can speak to. It was published a couple of years ago, but it basically showed that the MIPS program had not always weighted cost this highly. This was a change in 2022, and because of that, we were able to show that oncologists, as a result, received disproportionately lower composite MIPS scores. That resulted in fewer total payment bonuses, greater negative payment adjustments compared to physicians and other specialties. And it was really the first analysis to evaluate the impact of that cost scoring for MIPS participating physicians. So yeah, I think there's like some problems there. It tends to be a bit of a, source of frustration for oncologists participating in it. And I think that there's room for improvement with the MIPS program. If a practice is participating in the enhancing oncology model,
Right.
then there's that. That doesn't necessarily actually remove the practice participation from the MIPS program, though, because the way the MIPS program allows practices to opt out is by through its definition of what it considers an advanced APM. And actually, I think we had done an analysis suggesting that because the enhancing oncology model, unlike the OCM, is only a subset of cancer types. So it's only 7 cancer types. The OCM had like 21. A lot of community oncology practices in particular see non-malignant diagnoses. So benign hematology sometimes accounts for as much as 40% of our total patient volume. And just the way that all shakes out, participation in the EOM doesn't necessarily opt you out of MIPS reporting as a group. And so because of that, like there's not really an element of choice in terms of what practices are participating. Oftentimes it's either MIPS alone or it's MIPS and the EOM. And of course, the whole private side is completely different. I think there are a few key challenges that practices face in participating in value-based care. They can probably be categorized in a few different like buckets. One is probably um, broadly speaking, kind of like the economic framework for it. So, you know, um, a practice has to generally be of sufficient size to be able to spread case risk, if they're direct contracting with a payer. And they often need to be able to have, if they're sharing in downside risk, they have to have some kind of reinsurance, or they have to be able to own sort of the capital reserves that are required to swallow any kind of possible, shared losses that would involve recoupment to the payer. Um, and it's challenging. Like, I think, I really would not want, from the payer perspective, to view value-based care as like some kind of zero-sum game where there's winners and losers and that this is all very Darwinian, because ultimately, if a practice, closes doors or gets acquired or something like that, patient access suffers, and longer term, I think consolidation leads to higher prices overall for the payer. So I think we really should view kind of the lens of value-based care as payers and practices becoming allies in this. But often I do see that like it has the tendency to veer towards like an adversarial kind of framing, and I think that's not helpful or productive for anybody. I think there's like some serious data challenges that practices have to deal with in order to effectively participate in value-based care. So in order to like even identify kind of what is the right benchmark of spend to aim towards, I think you need to have a third party adjudicator really to look at all the data and sort of say like, here's our neutral, like trustworthy analysis of like an appropriate benchmark that everyone can agree to. Practices generally are not given kind of information such as historical claims data or total market claims data on their patients. And so if I'm just a physician in a fee-for-service framework, I don't necessarily have claims data to tell me that in the last 3 months, my patients were seen at all these other practices, or they were seen in the hospital several times, or what was the spend associated with those hospitalizations. So, we need to not only get that data, but we need to be able to have data analysis to like work through it and give you kind of insights into that. Similarly, what we call opportunity analyses at Thyme Care. So looking at not just kind of the patterns of spend, but like year over year changes such that a practice can say, I'm going to participate in a value-based care model, and I know that the areas to target are these subpopulations, these diseases, these regions, these physicians, so to be able to sort of drill down on where the opportunities are.
Mhm.
In real
Mhm.
time too, I think there's a lot of like data interoperability that can be challenging. So, most practices don't get immediate notifications about, if their patients were seen in the hospital. You have to subscribe to these ADT feeds. Large practices generally make those types of investments, but smaller practices may not. And so, like again, an enabler might pay for those feeds and offer that data to a practice, but a practice themselves may not have had that in place. I think value-based care has a really important role to try and have everybody be a little bit more mindful about the practice of medicine and like what things are driving up spend. I think everybody plays a role, right? But I don't think that value-based care operates in isolation. If we talk about kind of the 10% year over year growth in oncology spend, I think whether or not a practice is able to improve the hospitalization rate of its patients or make small drug switches that can potentially save spend. I think it's important. I'm not downplaying it, but I also think things like, what is the landscape of oncology access? Practices in the last 10 years have overwhelmingly been acquired by hospitals because of sort of the changes in the Affordable Care Act relating to the expansion of 340B. And I think, that the site of service differential between community oncology and hospitals can sometimes approach 30 to 40%. So that's important. And that's something that I think requires a broader policy approach, bigger than like kind of the things that a single practice can do. I think there's what can we do in terms of like the pharmaceutical innovation? On the one hand, it is incredibly important. Some of the new therapies that pharma is putting out in oncology are truly just like marvels. And I wouldn't want to impede that, but we should also like think about the cost of therapies that come out from that end. And oftentimes the cost is informed by the number of like middle managers along the pharmaceutical supply chain. So things like pharmacy benefit managers and like all of that kind of play a role. And so it's a little bit difficult to disentangle, but all of that would need to really be addressed to think about the cost of oncology care. But value-based care is a portion of it. It's not the entire story. Recently, I think the leaders at CMS had put out an editorial in the Journal of Clinical Oncology Practice, where they suggested, towards the end that maybe mandatory models are the only way in which like this whole field can evolve to really garner participation and make a dent. Um, I would be a little bit wary of that. I think there's probably a ways to go before mandatory models are really the way in which we should operate. Because I think that there's a lot that we need to iron out in terms of making sure that the models that we have in place are ones in which we're actually achieving the goal of improved quality and reduced costs without putting people out of business or without making it very difficult to operate as an oncologist. So I think there's a ways to go. I think that would be an interesting goal to shoot for, but all that to say that there's a lot that we need to do to improve the process along the way.